Good morning, everybody, and welcome to today's webinar on the Medicaid Sustainability Initiatives and the Impact on Providers. Before we begin, I would ask for our Spanish interpreter to introduce the service today.
Buenos días, mi nombre es Julieta y brindaré servicios de interpretación en español. En un momento este servicio estará activado. Para escuchar la interpretación en vivo en español del evento de hoy, seleccione el módulo Interpretaciones en la barra de herramientas de Zoom y luego seleccione Español. Tendrá la opción de silenciar audio original si desea escuchar solo el español. Este módulo de interpretación se activará momentáneamente.
All right. Thank you very much for joining us today. Next slide, please. My name is Cassandra Keller, and I am our Community Options Benefits Section Manager. So what that means is my teams oversee all of our home and community-based services, in addition to long-term home health and private duty nursing. And I've got my wonderful team here today to help with some of the background actions and managing the chat, the question and answers and what have you. So we will be recording the webinar today and posting one of the webinars to the website so that you can have this for the future. If you need interpretation services or closed caption, Kelly has so kindly put that in the chat of how you can do that. And then just a couple of other notes for today. We are not using the chat, but we are using the Q&A function. Please submit your questions there that you have. I don't think we're going to have time to go through all of those today in terms of an answer, but it's absolutely going to help formulate a frequently asked questions that we plan to post and publish very shortly. So I would imagine if you have the question, there are probably other providers out there who have the same question. And while today's webinar is focused primarily on providers and the impacts to providers, we do welcome everybody here today, family members, advocates, members themselves, even case managers, but please note that this information is geared toward providers and the type of, actions that they will need to take in order to implement these initiatives. Also, if there are questions that you don't want to put in the Q&A today, we've linked in the chat our Google form that you can submit your questions to as well, and we will work hard to get those answers developed and posted as soon as possible. Next slide, please. All right, we have a tight agenda today, and I do want to try and leave some time at the end if there are questions that people would like to come off mute and ask their questions, but we're going to do a little bit of background setting in terms of where we are and how we've gotten here. We're going to go over those sustainability actions and what those timelines look like, and then we will wrap up and have some time for you to ask us questions. Next slide, please. So I'd like to thank you all again for being here with us today. I think it's really important for us to understand why these changes are needed. Before we get into the details of the policy and the rate changes that are happening, I wanted to start by naming something directly. This is a really heavy topic. And when we talk about reductions or tighter controls, it feels personal and it is very impactful. These decisions that HCPF has had to make affect real people, members, families, caregivers, providers in those communities. So I want to acknowledge that up front. If you're coming in today's webinars with concerns or frustration or even uncertainty, you're not alone. At the same time, it's important that we're clear about the purpose of these changes. The core reason is simple, even if the situation is complex. We're making these changes because we have to protect the long-term sustainability of Medicaid and long-term services and supports in Colorado. So services can remain available not just this year, but 5, 10, even 20 years from now. Next slide, please. As many of you know, Medicaid consumes more than 1/3 of our state's budget. This year, our state has experienced limited revenue growth from TABOR and other fiscal constraints. On top of that, there have been federal policy changes like H.R. 1 that are increasing the state's financial obligation. With that, the state faces a structural budget deficit. Without action, Medicaid and long-term services and supports costs specifically will outpace revenues, meaning that if we do not take action, nearly every single new general fund dollar will need to be dedicated to Medicaid, leaving no funds for other state fund obligations. So we have to take action to ensure that our program spend aligns with funding we have available. Next slide, or not next slide. Kelly, if you could do the click for the animation. One statistic you'll often hear is that long-term services and supports population serves just 5% of the Medicaid population, but consumes 42% of the overall spending, and that's pretty standard across the nation. Serving people with disabilities and older adults are what Medicaid programs are designed to do, and appropriately so, but these services are expensive. However, this creates perhaps a disproportionate responsibility to make sure that LTSS programs fit within our funding and are available now and in the future. Next slide, please. When we look at home and community-based service waiver programs, we can see that the significant growth is happening in enrollment. For example, there's growing enrollment and increased demand among children and older adults. The state also anticipates future increased enrollment with the rapidly growing aging population in Colorado. Then, once members are enrolled in these programs, they're using significantly more services than they have in the past. So what we know is that without changes, LTSS spending will exceed available funding. The sooner that we can address unsustainable trends, the less deep of reductions we will need to make in the future. Next slide, please. So, workforce shortages, increasing wages, all of these things have significantly raised the cost of delivering care. So we're now in the position of needing to adjust our policies to align with these rising costs. As we go through this webinar, I invite you to keep two things in mind. These changes are about sustainability and long-term access, not just short-term savings. Additionally, providers play a vital role in implementing these changes and ensuring continuity of care. So with that foundation, let's walk through some of these solutions and supports for what's changing and what it means for you as a provider. Next slide, please. Because of these cost drivers, HCPF is implementing several components for solutions and support that start at the authorization of services. One, HCPF is implementing caps on personal care, homemaker, and health maintenance activities, as well as community connector services. We also have case managers utilizing the new Direct Care Service Calculator for justification and documentation of service authorizations for personal care, homemaker, and health maintenance activities. Case managers are also going to be collecting, as a requirement, they will be collecting health maintenance activity documentation to support the authorization of the service. Case managers are also utilizing these new task standards for effective authorization of services. There are set times for each task. Some tasks are at 0 if the task is not age appropriate. These things together will ensure that we can maintain the availability of these services across populations, ensure cost savings, and effective authorization of services. So I know you're all thinking about when will this all be implemented, and we will go over the timeline on the next few slides. Next slide, please. So we have a couple different things happening, but sure, next slide. Oh, keep going. Sorry, Kelly. One more. One to the next slide. Sorry, Kelly. Okay, so a lot of these changes are going to begin on April 1st. So the annual limits begin being applied for personal care, homemaker, health maintenance activities, and community connector. That's all going to start on April 1st of 2026. But I promise you, this is not all happening in one fell swoop. Everybody doesn't have to be at these new caps on April 1st. We plan on doing this in a rolling implementation. So case managers received training on all of these initiatives and the timelines last week. And so what they're doing is they will begin implementing these for members who have a continued stay review or their annual certification beginning April 1st. So that means that members whose new PAR and service plan starts in April might start getting these changes put onto their service plan. So they're talking with the member, talking with their families, getting these all set up so that it can be effective April 1st. We will have members doing this at their continued stay review or at a monthly, one of their quarterly monitoring visits. All of these things, every member will have these changes implemented into their prior authorization and service plan by November 30th of 2026. So it's going to be at a staggered implementation, but everybody will have this completed by November 30th. In addition to the caps, the April 1st, we will have Community Connector, the cap of no longer allowing the service to children over 6. That's going to be effective April 1st, and that's actually going to be effective for all members. So case managers will be removing prior to April 1st, but effective April 1st from all members with that service on their part. Lastly, on the April 1st timeline and that staggered implementation, case managers will begin categorizing each member for their individual residential service and support setting into either the staffed home or the shared living environment. Next slide, please. Okay, one of the things, excuse me, sorry. The other couple things for that April 1st deadline, we have everyone is going to be, the process started following age-related service-specific guidelines and personal care, homemaker, and health maintenance activities. You're going to be signing service plan signature pages as they come to you. You're only going to bill according to the authorized tasks and services, ensure sufficient and adequate caregiver staffing for all members, finding out if alternative caregivers are needed, and backup caregivers are a must. You're going to be providing care coordination following HCPF and CDPHE rules. And then for Community Connector, you're going to cease billing for those members who are younger than the age of 6. And then again, for IRSS, you're going to be categorizing those IRSS settings, staffed home versus shared living, and you'll be needing to make sure you notify case management in writing of any of those changes. So if you are falling into a different category than previously, you would need to provide that information to case management. Okay, next slide, please. All right. We're going to talk a little bit about age-appropriate guidelines and how next slide, please. As we've implemented Community First Choice, how that plays into age-appropriate guidelines, parental responsibility, and how services are authorized. Next slide, please. So case managers will be authorizing services based on the age-appropriate task standard. And this I want to make sure is clear for personal care, homemaker, and health maintenance activities, as well as Community Connector. So what this means is that for tasks that are not age appropriate, they will not be authorized. Time will only be authorized when the care is extraordinary. Extraordinary care is a standard that applies across all direct care services. When a service is provided by a family member, it must meet the definition of extraordinary care, regardless of the specific service type. The key consideration is whether the care exceeds what a family member would ordinarily provide to a person of the same age without a disability or chronic illness, and whether it is necessary to ensure the member's health and welfare and prevent institutionalization. Extraordinary care applies only when the care exceeds what a family member would provide. The service is necessary to ensure the health welfare of the member. The service helps prevent institutionalization, and it meets the service definition and documentation requirements. So I want to give a couple of examples here. Parents providing skilled medical support to a child. A parent provides daily tube feeding, suctioning, and seizure monitoring for a 6-year-old child with complex medical needs. These tasks exceed what a parent would ordinarily provide to a child of the same age without disability and are necessary to maintain the child's health and prevent hospitalization. How this is applied. So because the service exceeds typical parental care and are medically necessary, they meet the definition of extraordinary care and may be authorized when provided by a family member. Another example of a sibling acting as a primary caregiver to an adult member. An adult sibling provides daily assistance with mobility, medication management, and frequent monitoring for an adult with an intellectual disability and significant medical needs. the level of care exceeds typical familial support and is essential to prevent institutionalization. These services meet the definition of extraordinary care and may be authorized when provided by a family member. So a parent or a legal guardian with responsibility means that the legal rights and duties held by a parent or a court-appointed legal guardian to provide for the physical, emotional, developmental, and functional well-being of a child under age 18, including the responsibility to assist with or oversee activities of daily living and instrumental activities of daily living necessary for the child's development. When determining service needs for children, case managers are needing to distinguish between care that is typical for a child of the same age and care that exceeds age-appropriate expectations. Only supports that rise above normal developmental caregiving and meet the definition of extraordinary care may be authorized. What all of that means for you is that it is possible that there may be reductions in services that members have previously been authorized that were not age appropriate. So there may be reductions in services to the members that you're serving because of the implementation of these age appropriate guidelines. Next slide, please. So with all that, we're going to go into a little more detail about the first set of caps that are for personal care, homemaker, and health maintenance activities. Next slide, please. This slide shows you a high-level display of the caps for these three services and that the annual limits and how that's going to translate into approximate daily hours. Any authorizations above these limits require department approval, and case managers will complete that process. This is an exception process that is not driven by the provider, but by the case manager. There are additional lower-level approvals that are required at the task level. Providers should know that case managers must complete these processes before they will be able to provide an authorized PAR to the provider. So all of these exception requests would need to be completed before a PAR is created. Next slide, please. So personal care services is a covered benefit available to members enrolled in Community First Choice, designed to help members with daily tasks that they're unable to do. Personal hygiene, eating, walking, transferring, positioning, toileting, and the likes. Those are all tasks under personal care services. Next slide, please. In addition, we've got protective oversight under personal care. We're going to review protective oversight today because the definition of protective oversight now has a clear, more defined definition, and it also has a new limit. Protective oversight means providing active line of sight supervision requiring immediate intervention to prevent harm when a member's disability, memory, or cognitive functioning related behaviors or impairment place the member, others, or property at risk. Protective oversight does not include restrictive practices unless a documented rights modification is in place prior to the provision of services. Note that protective oversight is only a personal care task and cannot be authorized as HMA as well. Next slide, please. So protective oversight includes intervention time, including but not limited to verbal redirection, blocking access to hazards, removing dangerous items, or hands-on guidance. Protective oversight shall only be approved when the documented evidence of risk requiring regular and predictable intervention within the last year. The member service plan must include the frequency, scope, and duration of intervention required. Protective oversight shall not be authorized for purposes of companionship, childcare, general supervision, reassurance, emergency or crisis intervention, or routine monitoring that's not necessary to address a disability-related safety risk. Protective oversight alone cannot be the sole reason for the visit of service. So I say all of that because over the past several months, we have seen very high authorization of protective oversight for not approved purposes. Hence the reason that HCPF has had to modify the definition and further rein in how this service can be utilized. So there is, as mentioned, a limit of 7 hours per week of protective oversight, and anything above that needs department approval. Next slide, please. Specifically, protective oversight for children. It's only allowed to be authorized when the level of supervision requiring intervention is substantially greater than what is typical for a child of the same age without disabilities. Protective oversight cannot be authorized for routine childcare, typical parental monitoring, or supervision that is age appropriate and expected for children of the same age. Let me give you a couple of examples. A 12-year-old child with an intellectual disability and epilepsy engages in frequent self-injurious behaviors, such as headbanging, and that's all triggered by sensory overload. These behaviors occur daily and require immediate intervention to prevent injury. Another example is an 11-year-old child with significant emotional and cognitive impairments that has frequent, unpredictable, aggressive outbursts that include hitting, biting, or throwing objects at others. Line of sight supervision is required to intervene quickly and prevent harm to the child, siblings, or caregivers. Lastly, we have an example of an 8-year-old child with sensory processing disorder and limited danger awareness engages in unsafe sensory-seeking behavior such as climbing furniture, jumping from high surfaces, or running into walls. Caregivers must intervene multiple times per hour to prevent injury. These examples are for when protective oversight might be authorized for a member, but not in lieu of other necessary services like behavioral supports. Next slide, please. We're going to talk a little bit about homemaker services. So homemaker services are general household activities provided in the home of an eligible member to maintain a health and safe home environment for a member. They include things like appointment management, bed making, dishwashing, meal prep, light routine house cleaning, laundry, and shopping. Homemaker services must be completed within the permanent living space, except if we're looking at acquisition, maintenance, and enhancement, AME, of skills, laundry, or shopping. These services must be for the benefit of the member and not for the benefit of other persons living in the home. Next slide, please. Okay, so legally responsible person as it pertains to homemaker. The definition is legally responsible person means any person who has legal responsibility to care for another person. For children, this means the parent of the caregiver, or the parent of the minor child, and for adults, this is limited to a member's spouse. It does not include the parent or legal guardian of an adult child. We have, next slide, please. So we have some new limits as it pertains to homemaker services and the legally responsible person that can provide the service. The new annual limit on homemaker is 4,500 units, which translates to about 3 hours per day. The new limit of legally responsible person homemaker is 5 hours a week, which used to be at 10. There is a limit of 2 legally responsible persons that can be paid caregivers for a single member. Even if they have more than two LRPs, only 2 may be paid. So one member may have up to 10 hours of legally responsible person homemaking, 2 different caregivers. So it could be a mom and a dad or mom and mom, whatever the situation is. You can have 2 LRPs provide that service, but no more than that 10 hours. These new limits align policy when we look at other Medicaid programs where there's often a cap on those caregiving hours. This is a quality-focused action as well as a sustainability action. There's no exception to this individual LRPs going above 5. So case managers, providers, there's no request that you can make to exceed this amount. Now, a member may absolutely have more than that 5 hours per week of homemaker. They just need a different person to provide those additional hours. Remember that homemaking hours are inclusive of that LRP, not in addition to. So they want 10 hours, 5 hours from the LRP, 5 hours from a different caregiver. Next slide, please. Okay, lastly, we're going to talk about health maintenance activities. Those are skilled, routine, and repetitive health-related tasks furnished to members in the community or in their home. These services must be necessary for health and normal bodily functioning that a person with a disability is unable to physically carry out. These services are available through CFC or Community First Choice. Providers, please note in making sure in order to provide HMA, you must be licensed as a Class A or Class B home care agency and certified to provide in-home support services. As of December 22nd, 2025, case managers will be authorizing health maintenance activities using the new direct care service calculator and the HMA documentation guide to support determining when a service is skilled and how to document it. Next slide, please. HCPF has identified frequent gaps in requiring HMA documentation. Missing or outdated documents limit a case manager's ability to verify skilled care needs and to authorize services appropriately within the person-centered support plan. To address these issues, HCPF has developed a new HMA member checklist and updated the CSC documentation guide. Members self-directing their services through consumer-directed attendant support services or in-home support services must now provide supporting medical documentation for HMA tasks to their caregiver in preparation for their level of care screen or CSR. Case managers must collect and retain this information in the member's record. The HMA checklist should be provided to members in anticipation of their assessment, so they will be getting this from their case manager. This checklist outlines the kind of medical documentation that will be required and from whom it can be received from. These are not self-reported diagnoses or medical documentation dated. It needs to be from a medical professional in those instances. Documentation must be current, meaning within the last 1 year for children and 3 years for adults. Members and case managers will use the CFC documentation guide and HMA documentation checklist as part of the intake, enrollment, and person-centered support planning processes. These tools are intended to strengthen consistency, accuracy, and transparency across assessments and authorizations statewide. In the event an HMA task cannot be supported by recent or relevant documentation, it must not be approved as HMA. However, the task may be approved as personal care if applicable. Providers. If a member asks for help with documentation, agencies can support this. However, the documentation must be medical or clinical in nature. Next slide, please. So the timeline for this is effective immediately. This began January 5th, 2026. So for new members without previously authorized HMA, documentation must be provided before any HMA services are authorized. For members with current HMA services, the authorizations will remain valid until the last day of the certification period or until a revision resulting from a change in service needs is requested, whichever occurs first. Existing services may be carried over into the new certification period while HMA documentation is obtained. For any new HMA services requested as part of a revision, documentation is going to need to be provided. So this is something that case managers and members are going to be working up to, gathering documentation. So really wanting to make sure members get this information early so that they can begin this process. Next slide, please. All right, so most importantly, what you need to know. Providers may support the member as the service plan is developed, but they cannot pressure the case manager to authorize hours that are not supported by an assessed need and also that is not age appropriate. Providers, we ask that you sign the service plan signature page, otherwise a PAR cannot be completed. Case managers alone are submitting the exception request for soft caps, not providers. Providers and employers are responsible to ensure only authorized tasks and services are provided and billed accordingly. The provider is responsible for recruiting, ensuring adequate staffing, and ensuring each caregiver can provide high quality and safe care. This includes recruiting staff beyond family members. And lastly, care coordination is a provider requirement. Document what other services and providers are in place for your members. Please follow Colorado Department of Public Health and Environment and HCPF regulations on care coordination. Next slide, please. Okay, the hottest topic of all that we have got on our plates is the cap on caregivers. So in addition to the 5-hour cap on legally responsible persons providing homemaker for caregivers, there's now an overall cap for caregivers that apply across multiple services. Okay, so we are implementing a weekly limit of 56 hours per caregiver for a single member. Excuse me, this limit is for the total hours across personal care, homemaker, health maintenance activities, long-term home health aid, and long-term home health nursing services per member. Please note this excludes private duty nursing. The 16-hour per day limit for caregivers across all services and members served will remain in place. A caregiver may work up to 56 hours a week per member. Additionally, each caregiver may work up to 16 hours per day total for any number of members they care for. A caregiver may work for more than 56 hours per week if they provide care to multiple members, so long as they don't exceed that 56-hour per week per client or a 16-hour per day total. This means that there is a limit on the number of paid caregiving hours someone can provide each week. This doesn't mean case managers need to reduce a member's authorized hours. Case managers are going to be speaking with members about the caregivers they have and make sure that they understand and are aware of these new limits. If caregivers are above the weekly limit, work will need to be done with you all to ensure and identify additional caregivers who can provide this support. If a member needs more than 56 hours per week of services, members need to be working with the provider agency or their employer to recruit additional caregivers. We have different resources available. We can send them to the Direct Care Careers website or additional support for members self-directing. There's information and assistance through Consumer Directive Colorado, which is another free resource that can help support members. There is no exception for children or adults on this limit. In rare acute emergency cases, let's say that a caregiver got in a car accident on their way to your house to provide, or to a member's house to provide services, and they're unable to show up for a shift. That is an absolute case of an acute emergency, and there is no need. The original caregiver, the family caregiver, can continue providing services in that instance. But outside of those documented emergencies, no exceptions will be allowed. There's no exception request that a case manager can submit to the department for review. Members needing care beyond 56 hours per week may receive that paid care up to their authorized amount provided by multiple caregivers. Next slide, please. So what you need to know. As provider agencies, you must ensure that any approved hours above the caregiver limits are provided by different caregivers. Provider agencies must support members and families in finding alternative caregivers to support homemaking services as needed. Next slide, please. Okay, we're going to move into the new age limits and caps for community connector services. Next slide, please. So another service some of you may need to become familiar with, or you are familiar with, is a community connector service. This service is available to members on the community or Children's Extensive Support and Children's Habilitative Residential Program, CHIRP. These are highly specific, purpose-driven services intended to support one-on-one community integration for members aged 6 and older who have an exceptional need that exceeds age-typical parental or legal guardian responsibilities. They're provided to a single child who is in need of extra support to connect with, meaningfully and actively participate in, and use community resources. Paid supports for this service are actively providing support throughout the activity. Services must be provided one-on-one. If other children are present during an activity, another parent or responsible person must be present to supervise those other children. The purpose of this service is to support community integration and independent participation through relationship building, skill development in community settings, and delivery under a person-centered plan along with available supports. Next slide, please. So the new limits. There's now, first, there's an age limit, as I mentioned, for Community Connector. This benefit is now geared toward school-aged children, age 6 and up, with an assessed exceptional need. For children under the age of 6, accessing and engaging with the community are considered typical parental responsibilities. The Community Connector age limit will be effective for everyone that it applies to beginning April 1st of 2026. The PARG will be updated with the end date and notify the providers that the service is ending. So you should be hearing from case managers that that service is ending. Any billing for, one, and after will be denied. There is no exception process to request services for a member. Next slide, please. In addition to the limit on age, for children over the age of 6, Community Connector has a new limit that will also be effective April 1st. the annual limit on Community Connector will be 1,040 annual units. This is a reduction by half from the previously allowed amount. The 1,040 unit limit is not a given for each child. Authorizations by case managers must be done based on assessed and exceptional need, clearly documented goals and strategies, appropriate community activities, and reasonable units tied to specific activities. Case managers may request Community Connector units above the limit through the exception process, and the department may approve those additional units on a case-by-case basis. So again, this is something that the case manager can request, not something that the provider does. Next slide, please. We get a lot of questions about the type of activities that are appropriate, so I just want to share that briefly. I won't read out the list, but for children ages 6 years of older, here's a list of activities, but it's not inclusive. Community activities are often not free. The service does not cover the cost of these activities, so please note that. The units for Community Connector are only for the support personnel that are helping the member meaningfully participate in community activities. Next slide, please. Activities provided exclusively for recreational purposes as well as passive presence in the community are not really a benefit of this service. Examples of activities that are excluded include going for solo or family walks or hikes, fishing alone, to the park alone, that type of thing. Ensuring the safety of a child in a parking lot or near roads by making sure they look both ways while crossing the street. This is a typical task of a parent of a young child and shouldn't be an activity delivered or billed under Community Connector. Please note that Community Connector services must not duplicate or replace other waiver or non-waiver services. For example, personal care, therapies, behavioral services, or other supports that address different needs. And they must be used in place of social skill development that should occur during school hours. Next slide, please. Okay, what you need to know. Claims will be denied for kids under 6 after 4/1. 1,040 annual limit will take effect 4/1/2026 and forward. This will again be done on a rolling basis. It won't impact members all at once on April 1st. Please only bill according to the prior authorization request and service plan. Make sure you're following age-appropriate guidelines about what are appropriate activities. Meaningful engagement, not brief, recreational, segregated, or just basic supervision. Those are not part of the service. No other children under the paid to support supervision, and this cannot duplicate other services. Next slide, please. Okay, lastly, next slide, one more. The way individual residential services and supports are defined is changing. Right now, it's a little unclear and does not account for the variety of settings available to members receiving IRSS. We have 2 different rates, and it's been very confusing about which rate should be used for each setting. So we are clarifying the definitions of regulation and within our billing manuals for how they should be categorized. Host homes, family homes, member homes, and staffed homes are clearly going to be defined, and rates are appropriate aligned to account for the operational and administrative costs for each. Right now, we're struggling because we cannot support paying a host home provider a different rate than a family caregiver who is doing essentially the same work with the same levels of overhead. So we are aligning that those be paid under one rate, and then a staffed home that has rotating agency staff has that higher rate to account for those additional costs that would be part of that setting. Next slide, please. This will just give you a little bit of a distinction between, so the IRSS staffed home at that higher rate. IRSS supports provided by residential agency staff who do not serve as a primary caregiver. Care must be managed by the provider agency. And family members, if they don't live there, not living there full time, they can be staff in that staffed home. We also have the shared living environment. This encompasses host homes and family caregivers. So this is support provided by a primary caregiver, somebody who resides there and provides care 51% of the time. They reside in that home most of the time. So they will be considered a shared living environment. Next slide, please. So we ask that you follow the following action. So you're going to categorize each member's IRSS setting according to the updated definitions. Will they be under a staffed home, shared living environment? You're going to notify the case manager in writing of a change if there is a change. Maintain documentation to demonstrate compliance with service delivery records, residency verification for paid primary caregivers, and any payroll or payment records for staff. Provider agencies must understand that failure to comply may result in recategorization of setting type, corrective action, or even recoupment. Provider agencies will continue to demonstrate compliance with all billing requirements and in rule and in the billing manual. Okay, last slide, we've got some resources for you all. I know we have thrown a lot of information at you. I know there are lots and lots and lots of questions in the question and answer. We will certainly work on getting to those, but if there are folks who would like to raise their hand and ask some questions, we will try our darndest to answer those. But I just want to make it very clear, all of these changes, they are part of the executive order. This is a directive that is coming out of from the governor. We are in the process of promulgating rules through the Medical Services Board process. And we've also been concurrently issuing operational memos so that we have operational guidance to our case managers, to our providers, to our members, so that they understand these changes that are upcoming and so that conversations can begin as soon as possible. At the same time, we are in the process of receiving federal approval on all of these changes, and we anticipate approval by that April 1st deadline. So while none of these things have been solidified in regulation or within our federal agreements, they are all in the works. So we are just making sure that case managers have the information that they need to begin this work. You all as providers have the information you need, and members know what's coming down for them. Okay, without further ado, I will, wow, lots of hands. I will hand it to Michaela Herman. If you'd like to come off mute and ask your question or make a comment, please do.
Deb, can you?
Yes, now I can hear you. Thank you, Michaela.
Yeah, no, I'm good for now. I think I don't have any question right away. I certainly would like to review this because some section were pretty quick, and so I need to just go over them again. But I don't have a question right now.
Okay, great. And please note we will be posting we have two sessions of this webinar. We will be posting one of them. We will post the slides and then any other guidance documents along with them. Okay, Maureen, I see you are next. You may go ahead and come off mute.
Hello, can you hear me okay?
Yes, we can. Go ahead, Maureen.
Okay, sorry. Yeah, I just had a question. The slide deck doesn't talk at all about what to do if there is a desire to have an exception or appeal process. And I feel like that's a real, what do I want to say, shortfalling of these slides as to how does a provider help a client or a member who disagrees with the determination and either wants to exceed the cap or use the exception process or do an appeal.
Sure, good question.
There's also no mention of the right for a Medicaid member to be given a notice of action. None of that's in the slide deck.
Maureen, you are correct. That is not part of this provider training. However, case managers received extensive training last week, and part of their training was extensive information about the notice of action process. So if they are needing to submit or if they're needing to make a reduction or adverse action to a member, the rights of a member and an NOA that would need to be sent. Additionally, case managers will be the one who are submitting the exception request, and we've provided training and information on how to support a member in doing an exception. So because those are case management functions, those were not things that were covered in today's training that was geared toward providers.
Okay, is there a way for us to have a copy of, get access to that recording as a consumer? I'm a provider and my son is a consumer, so I feel like I fall, I'm straddling those two identities, so
Yeah.
to speak.
So we'll
So,
take that back. I think there's resources that will be made available to members that are member specific about their rights and exceptions processes, but we'll take that back. I'm not sure about that training specifically getting posted, but we'll take that
yeah,
feedback.
because that's a real lack of information in the community. So I'd really appreciate you
Sure,
bringing that back. Thank you.
you bet. Thanks, Maureen. Okay, Tyler, you are next. Hand raised.
Hi there. Thank you for taking the time. And I know
You
this has
bet.
been a challenging situation for a lot of people. So I appreciate you guys putting this together. I just have two kind of, I'll summarize both my questions quickly. And if you have a clarification. So, I mean, all this is pointing to budget, sustainability, et cetera. So my 2 points, and I've asked repeatedly on surveys and emails and just haven't got clarification on the 56-hour cap. A provider is still responsible for servicing the entire authorization. So can HICPUF or somebody explain how that is a budget savings at all, whether we're paying 1, 2, 3 caregivers for the same authorization, all that budget will be used. So that's not really a budget saving. So how does HICPUF clarify this as a budget savings with that? And then number two, the second thing that's been mentioned on the caregiver cap is a caregiver burnout and reducing caregiver burnout. But a caregiver can work up to 112 hours for two members and be burned out. But
Yeah.
a single caregiver cannot work 112 hours for one member and be burned out. So can HICPUF or somebody clarify why one caregiver is burned out at 112 but not another?
Yeah, those are good questions. And you're right that the caregiver cap was couched with the initiatives for budget savings and sustainability, but this component is really less of a budget savings initiative and more of a health, safety, and welfare initiative of ensuring, as we've mentioned, caregiver burnout, not being heavily and solely reliant on family caregivers to be providing services, live-in caregivers to be providing those services. So we want to make sure folks are getting the services that they need. And if that means paying and having a full, all personal care hours being provided, so be it. There's not a loss there. We're not trying to save money on that. It really is the basis is ensuring caregiver burnout. But you're right. I think there is a little bit if you can provide 56 hours to two people, you may be actually burning out. I think that's where that 16 hours a day cap that still remains in place would come into play. But I don't think we expect that anyone really is providing that much care. But to that piece, I'll take that back because I don't know that I
Maybe
have
just
a solid
kind of
answer in terms of burnout.
it conflicts itself. Like
Yeah, it does a
you can
bit.
burn
You're right.
yourself out with two kids if you have two kids instead of one kid or whatever. And I guess my last follow up on that would be, with the IHSS and the CDOS model, the participant driven model, the family AR, the member has a lot of say in caregivers, as well, like approval. So, has HICPUF done any research and spoken to any, for example, single parents, they may not feel it's safe or they don't want to invade their privacy of having 2, 3, 4 other people in their home. So has HICPUF taken that into an account where it's a single mom, for instance, that's just trying to take care of their child who would otherwise be institutionalized?
We
You can't
have.
force them to accept a caregiver in their home from a privacy and safety standpoint, but now we're going to tell them that their child won't have the care that they need then.
So yes, Tyler, we have heard from lots of families. We do understand that is the situation for some families that a single parent is the only caregiver. But I think the concern is that one individual providing all of that care is not necessarily safe. But I hear you. I hear the concerns, and you're not the first person that has brought that to our attention. So thank you for your comments, Tyler.
Thanks.
All right, Victoria, you are next.
Yeah, Candace, it's Victoria. Nice to see you guys at the JBC hearing yesterday. I just had a quick question. Well, actually two. First, you said that you guys are still waiting on federal approval, but I was there when you told the JBC that you were moving forward with these cuts anyway, because in 20 years that you guys have had asked permission from the federal government for anything, they've never turned you down. Um, You have not told the JBC or the Medical Services Board or any of the other meetings that I have attended that you guys have already started these cuts. These cuts are already happening. As an advocate for impacted caregivers, I am seeing every single day families coming to me how their CM reached out to them from nowhere and was like, even though you just got approved, we have to completely redo this and have hours cut and completely redone. And I'll tell you what, Candace, I'm one of them. Um, my daughter was just approved for her yearly renewal in December 2nd. And I've already had to look through the calculator and things for my two children. So you guys keep saying an April 1st deadline, and yet everybody out here in reality is trying to tell everybody over and over again that you guys have already started these cuts. They're already impacting families, and the fact that somebody can submit a revision and they have 15 days for it to go into effect. So that means that a family could uh, lose a whole lot of hours or all of their hours and about 80% of their income within an 18-day or 15-day period once that is submitted. And you guys have not told families that either. And then the other thing is,
Victoria, is there we have lots of folks with their hand
yes, I
raised. I
have
don't
a
want to cut you
question.
off, but if there's a question that you'd
No,
like to
sure,
ask.
I do. Why are you not being honest with anybody about those things? That's my question. You can put me on mute now.
All right. Well, thanks, Victoria. I've listened to JVC. I won't speak to all of those things. We are in the process of getting federal approval. I think the comments of never been turned down by our federal partners was specific to rate increases or decreases. So we are, as I mentioned before, in the process of seeking federal approval. However, we are also operating under the executive order, which drives and dictates that we move forward with these changes. So that is what we are doing. We have made sure case managers have heard loud and clear that these, if there are reductions that need to take place, that reductions do not happen and are not effective until April, or they're not effective anytime before April 1st. So if there are specific examples that you have where you have a case manager who is reducing services to the limit or any of these other caps, please let us know, because that is not the directive from HCPF. These changes are not effective in terms of the soft cap, the caps on caregivers, the community connector changes. Those changes are not effective before April 1st. Okay. We've got time for probably a couple more hands. Leah, you are next. And I forgot to ask this, if you can, when you come off mute, tell us who you are and who you represent. That would be helpful. Thank you.
Hi, can you hear me?
I can. Thank you, Leah.
Hi, my name is Leah Brahms, and I have a little boy that is 8 with a rare genetic condition that impacts him medically, and he has multiple complexities there as well as behaviorally. And I'm sorry to piggyback on everything, but this 56-hour cap is insane. I don't understand why y'all are actively going after the most vulnerable of the most vulnerable, i.e. the 24/7 care kids and single parents, neither of which I am. I'm just appalled that y'all have made this decision on the backs of these families that are going to lose their homes, have food insecurity. I don't believe that you're listening to us. And I'm not sure why I'm not sure why y'all can't understand that regardless of the lists of case management agencies in terms of skilled caregivers, there are none. There are none that will go for that low of a rate, and there are none that are trustworthy enough. And the other option is to just institutionalize kids, which winds up costing you guys way more. It's already been proven that it's way more cost efficient and safer for the child or the adult child to be with the family in the home.
So thank you, Leah.
I don't understand
Leah,
why you can't
I'm
understand.
sorry to cut you off. I think I want to respect your feedback and your opinion, but I do want to also respect the fact that this is a webinar that is geared toward provider agencies and how they implement these changes and the processes. not discuss the specific policies of that. So thank you for your feedback and your commentary. We do hear you and hear your concerns.
I know you hear me all the time.
So,
You hear
Leah,
everybody.
I'd ask you that you'd
Thank
mute,
you.
and I would turn to Carmen if you'd like to come off mute, tell us who you are and who you represent. We got time for probably one more hand after this. Thanks.
Thank you, Cassandra. My name is Carmen Morales, and I am a parent caregiver for one of your members. He's 20 years old. I do have questions, as you guys are saying, we need to work with our agencies. Just so you know, my son is 20 years old, and I have been on a wait list with our agency to have other care provided for us for years. And my question to you is this: when we have a person that we're caregiving for that needs skilled nursing, the only other options that we have are someplace like a hospital, rehabilitation facility, or a nursing home. So my question to you is, when we cannot find care and we are then, quote, able to have a 56-hour cap when most of us have been doing this for 20 plus years, where are we supposed to take our children? Where are we going to take them so that they can get that skilled nursing care? Because our agencies, unfortunately, Cassandra, have not been able to staff our concerns and what we have needed for the past 20 years. So my question to you is then, are we able to use a hospital, for instance, like an ER type of a situation where if we have to go and then work outside the home, take them there so they can have their skilled nursing? Because this is, from what I understand, when my provider writes a script for my son to have X amount of hours of skilled nursing, and HCPF tells me that to go with my agency, and I don't have that option, do I then leave him home? Do I take him to a care nursing facility where he can receive care?
All right. Thank you, Carmen. I hear you. I think we've got some resources that we can drop in the chat about finding alternative caregivers. But
I've tried, Cassandra. I've tried.
So Carmen, I'm not going to speak to your specific example here. Again, this is really pertaining to providers and how we can help them implement. I'm sorry to all of those that raised their hand. I hope that you have put your questions in the Q&A so that we can take these back and answer frequently asked questions and publish that information. But that is, we are at time and won't have time for any more folks to speak. But I really appreciate everybody participating today. Providers, if there are questions about how you implement this, either fill out the form, put it in the Q&A, or you can always feel free to email the HCBS questions inbox, and we actively monitor that inbox. But thank you everybody for your attendance and participation today.